about this because I'm excited as well. So our next presenter, Isha Williams, is a core faculty member and clinical training director in the CFT department at Adler University and has been core faculty there since 2013. She holds a Master's of Science in Cell Biology from East Carolina University, a Master's of Science in MFT from East Carolina University, and is a Doctor of Philosophy candidate in MFT at Virginia Tech, soon to be done, yes. She is licensed as a family therapist in the state of North Carolina and Illinois, an MFT supervisor, and is also a member of the board of directors of WMFT. So I'm very pleased that she's able to be here at that busy position. Just to skip down to Aisha's research interests are chronic illness in children and the impact it has on children and their families, spirituality as a coping mechanism, and culturally appropriate training and supervision. So, welcome.
So it's really nice to be here today. I was glad that I could come back and share some information with you guys. I was also a fellow in for the, I think it was maybe the 3rd year that the fellowship was in existence. And so whenever I have an opportunity to do something like this, I'm ready. So you can note that. You can note that. So I actually didn't give any background information on any of the slides, so I'll just tell you a little bit about myself. Just like pretty much everybody in the room, we came to the profession because of either we had an experience with therapy or we experienced a situation where we would benefit from therapy but we didn't get it. And said, maybe something should shift there. So that's the latter for me. I shared with a couple of fellows this morning about my background. My younger brother, he's 10 years younger than me. I'm in the middle. I have an older brother, 2 years older. He was born with some major health issues. And as a result, he had to have one of his kidneys removed when he was 6 months old. He went into renal failure with the remaining kidney when he was 8. My mom donated at that point, and he went into renal failure again in 2010, which was the 2nd year of me completing doctoral classwork. Yeah, interesting time. So I became the next donor. So I donated to him in December 2010. I'm glad to say, happy to report, he's doing fine. I'm doing fine. Life is great. But as I reflect on that experience, so when he had his first surgery, I was 10. And that was really traumatic. I didn't realize how traumatic that was until I became a therapist. Because as Dr. Brooks read, my first love was biology. I thought I was going to be a medical researcher and cure something, right? So also a result of family history. And so in that process, realizing that the medical establishment, medical professionals are focused on the patient. I mean, that's their job, right? That's what they're supposed to do. They're really not concerned about the rest of the family. It's peripheral, right? For kids, we want to know that the parents have it a little bit together because they're the ones who actually have to help their children manage whatever's happening, right? So the check-in is kid, parent. Oh, there are other people who are involved? Oh, by the way, you do have 2 other kids. How are they? How's school? That was my experience. And so, so my response to that, being 10, up until I graduated from high school, I thought the way that I would attend to those kinds of things were if I could actually cure disease. That would be the way that I would help families not have to experience something like that. Clearly, that's not the route that I took. So, it was, I'm a non-traditional student. You can't tell that. So as I went through this process, I realized that the way that I would be able to help families, specifically kids who were struggling around chronic disease, would be to become a therapist. And at this point, I identify as a medical family therapist. So everybody's aware of what that is, right? Yay! Hopefully we've got some converts in the room. So I, interestingly, right, so this ends up being what my dissertation topic is about. And I had the opportunity as part of my work completing my internship for my PhD. I did a fellowship in Chicago. It's the Collaborative Family Healthcare Fellowship that's affiliated with John Rowland and the University of Chicago. So I was a behavioral health fellow, and I had an opportunity to be embedded in a tertiary care center, which is the endocrinology clinic, and a family practice. So I got that experience, which was fantastic, and then traditional therapy. I was like, okay. So through that process, I worked primarily with the pediatric patients, and so peds is everybody under 21. And in the field of diabetes, the reason they go to 21 is because when kids launch, whether they move out or they go to college, they like for them to still stick with the same doctor. Because they've had this doctor from whenever they were diagnosed up until then, because there's this transition period that I'm sure you guys are kind of familiar with, like when you go off to school, how sometimes you do what you're supposed to do and you don't do what you're supposed to do, you eat the things that you should or not. So that's very important when you have someone who is transitioning into adulthood and being responsible for their care and who has diabetes, especially type 1 diabetes. And so that's the work that I'm primarily going to talk about today. One of the things about this kind of work, when you get it, right? When you are identifying as a medical family therapist and you see the impact that disease has on families, you know, the first thing you're thinking is like, okay, where's the family? Like, come on, where, you know, there are kids, let's bring in the kids, let's bring in the whole family. How are the parents doing, or how is grandma doing? Like, whomever the family is, how are they supporting, or how are they being supported through the process of having to help their sick child, right? And so that's the exception, right? Medical professionals, they don't really get it. They're just kind of like, you do what now? Okay, so run that by me one more time. Like, okay, so I'm supposed to give up my time. Okay, we'll see. You know, and it's like it's a wait and see, because they haven't had that experience. They haven't had somebody who is a therapist embedded in their clinic. Now, if you happen to get into a clinic where they know that, oh my gosh, it's night and day. Because they're like, yes, come in. Yes, please. Yes, there's a patient. Please go see them. Yes. And they recruit you and have you doing the work. You're like, oh, I thought I was just going to be. No. You hit the ground running, right? Because there's the expectation that you know what you're doing and that you'll be helpful to the patient. And then, of course, it's the shift in language, right? In the medical setting, they are patients. So then you have this switch. So when I'm in regular therapy setting, I'm like, client, okay, these are my clients. And I go over here to put on my medical hat, and they're my patients, because they actually are a patient, right? They actually are the identified person who has an identifiable health issue. So it takes a little bit of a shift in like how you think about where problems are kind of emerging from, because yeah, they are kind of like the source of some problems. Now, we can't like dismiss the family dynamic, because whenever things like this happens, whatever family issues are happening, disease bumps them up by 10, right? So how many of you have a family member or self who would say that you have a chronic disease? So I have to add my hand to this, right? So I'll probably do a lot of self-disclosure in this presentation. think about that experience, and you think about your engagement with the medical profession, what are some things that you would say kind of characterize how that looked?
So my mother had a heart attack when I was in 8th grade, and it was she was in her 40s, it was very unexpected. And the medical team really didn't interact with me at all, but I was like a terrified 8th grader with lots of questions. But my pastor had just had open heart surgery, so he knew all of what was happening and walked me through like what my questions were. And if I hadn't had him, there would have been no interaction.
I think for me growing up, I was first generation here, so my parents didn't speak English, so I was at the age of like 8, 9 years old, and I was like the medical family therapist, because both my parents have insulin-dependent diabetes. So just having to speak with the endocrinologist and the nutritionist and this and that person, I just felt like there's a lot of toll that took on me and my family as well. And having to put that message back on the primary care physician was just like, I feel like I had to do that work because I was like, that's all my own personal stuff, but like I was the oldest male of the family, although I was 8 years old speaking English.
So my sister and her husband actually had diabetes, and she was diagnosed really young, but so we were pretty close growing up, and I didn't have a whole lot of contact with my doctor or her doctor, but I did know she was diabetic. But I was younger than her, I just experienced a lot of the symptoms without really knowing how to put it into a framework. So there were multiple experiences where, like, if we had sleepovers or I'd sleep in her bed, she would have a seizure in the middle of the night and she'd get really low. And I didn't know what that was, and I didn't have it explained to me until, there were emergencies that, were in some ways traumatic for me, that I didn't really understand what was happening for my sister. And so growing up kind of feeling like, with the knowledge that, like, if I hadn't slept in her bed that night, she could have potentially died if her blood had crashed, or things like that, knowing that there was this weight and responsibility on me as a sister and in the family that was never really explained to me by a physician or by my parents. A lot of ambiguity there.
I don't know if it counts as a chronic illness, but it was, my brother is autistic, so it's a developmental disorder. So throughout my whole life, there was kind of, my role was in a similar way, just kind of presumed that I would act as a support and as a teacher in a lot of ways for him. But, with autism, it's a whole team of, neurologists, ABA therapy, occupational therapy, speech therapy, and a lot of people coming in and out of the house, and I'm not really sure what's going on, and so I ended up doing a lot of research myself on it. Every school project that I had where I had to do my own research, I would research autism so I could understand it. But it wasn't really explained to me specifically by most of the clinicians.
I grew up living with extended family, which included my great aunt. She was developmentally handicapped from birth, so she also was undocumented here in the States, and so we didn't have access to resources to like help her out, and a lot of her anxiety. She had a lot of anxiety about like change or going out. Like we'd have to like tell her, it's so and so's birthday and we're gonna go out. You have to like warn her and like give her a lot of time to adjust. And there was a lot of times she just felt so anxious she was sick all the time, so she'd stay home. And as I reflect, my family loved her a lot, and I also wonder like what could have been this done for us in terms of helping her adjust and reduce her anxiety so she could have a better quality of life.
My Nana has type 2 diabetes, and in my early 20s, I would go with her to her doctor's appointments. And so oftentimes I would kind of be a translator. There were language the doctors use she wouldn't understand. And then there were also things that she wouldn't share. She would not disclose that she would sometimes eat things that she knows she wasn't supposed to eat. And so even kind of giving all the disclosures to the doctors. So like if they're seeing some of her numbers and they're like, well, it doesn't add up if you're eating the right things and doing this, then why do your numbers say something differently? And so she wouldn't oftentimes, she'd keep some of the things she knew were wrong to herself. So I kind of had to step in and say, okay, doc, this is what she's doing. And she knows she's not supposed to be doing it. So even in situations like that, I think it would have been helpful to have a medical family therapist come in the room and say, okay, let's understand why she knows better, but she's not doing better.
Yeah, I mean, and you think the very thing that you touched on, a lot of times, what my experience was in the clinic, because I actually got a chance to see some adults too, there's a lot of guilt and shame that happens for people who have type 1 or type 2, because for that very thing, they're like, I know my A1C is going to be wrong. Okay, and what is the doctor going to say, right? And every time, without fail, the doctor will say, your A1C is this. This is not good. What have you been doing? Right? The person already knows it. It's not like they are not aware that they've not been doing all the things that they should do. But because of the psychosocial stressors that are present in people's lives, that tends to not get addressed. Because the doctor's like, I'm looking at your numbers. Are you exercising? Are you eating right? That's really my area of concern, right? But that's not the totality of what happens when you have type 1 or even type 2, right? Is that there are some psychosocial things that are happening within the family, because I think our presentations were pretty well paired, because a lot of the things that happen around eating, cultural dynamics, what is expected around how you eat, when you eat, what you eat, that also impacts a person's ability to manage their diabetes well, right? And so there are some other things that happen with kids that, especially as they transition into adolescence, that becomes a little bit more challenging. And I'll touch a little bit on those a little bit later. But to get started with the presentation, so what I'm going to do is really give you like an overview of some developmental things for adolescents, look at what chronic illness is, what happens with diabetes, give you some background around that, and then we're going to talk a little bit about medical family therapy, because I'm going to use that as a lens to talk about what this looks like. Okay, so you get some background, and then we'll do some application. So the first thing that I'm going to have you do, and I'll actually read it. So I've got a little vignette here. This is the Miller family. And as we go through this, we're going to refer back to the family. And so I want you to maybe take some notes about some things that stick out to you. Maybe things that you might want to ask, or things that you're curious about. Okay, so the Miller family, they're an African-American family that's being referred to you because you're the staff therapist who provides services for patients who have been diagnosed with diabetes and their families. The family was referred to therapy because one of the children, Timothy, who is 14, is struggling with keeping his hemoglobin A1C in a healthy range. So that's the marker that they use to make sure that your blood sugars stay in a good, healthy range. And I'll show you something else about that a little bit later. His parents, Jonathan, who's 42, and his mom, Lena, are concerned that Timothy is not checking his blood sugars as often as he should and is skipping his insulin doses. Timothy was diagnosed with type 1 diabetes when he was 5 years of age during the winter break of his first year of school. He was hospitalized for a couple of weeks until the medical team was able to stabilize his treatment regimen. When asked, Timothy states, "I feel fine and I wish they would just let me do this by myself." Dr. Welch, Timothy's pediatric endocrinologist, reports Timothy's hemoglobin A1C is 9.5. Where they'd like him to be is below 7. And she wants you to get him back on track with his diet and his regimen. Jonathan and Lena's other children, Nicole, who is 8, and Daniel, who is 5, do not have any other health issues and are able to eat without restrictions. Both Timothy and Nicole are involved in after-school sports. However, Daniel is not involved in any after-school activities. Both Lena and Jonathan report that they feel overwhelmed sometimes, having to make sure Timothy is complying with his treatment and balancing attending to his needs as well as to the needs of their other 2 children. Lena states, "I'm exhausted by the end of the week. I don't feel like spending time with our friends or family." Jonathan adds, "We're doing the best we can." So just be thinking about them as we go through this information. Okay? All right, so because all of you have been adolescents, this should be familiar to you. So when we think about the hallmark of adolescent development, we usually call to mind Piaget. Yes, there are some critiques to Piaget, but however, that continues to be where we focus, right? And so for adolescents, that's that transitional period where they are now able to understand logic and abstract concepts, right? And so things are no longer black and white. They can now appreciate shades of gray, all right? They're able to use metacognition, which means, like us, they take the meta perspective about thought. So they're able to think about their thought, right? And then their increase in problem-solving skills, okay? So when you're thinking about this normative development for adolescents, this is really important because this is what helps them attend to their growth and development, helping them understand life in a different way. Now, one of the hallmarks is that adolescents, they struggle a lot, right? Because they're like, oh, I want to be a grown-up. And then like, no, I don't. Right? So it's like that push-pull, you know, like, oh my gosh, I don't want to spend time with you, but take me to the mall. You know, and it seems very conflictual because you're like, you're driving me bananas. Like, can you just, if you want to be an adult, be an adult. Well, but they can't because that's the developmental process that's happening. They're struggling with that. And so they want this solid sense of independence, and parents struggle with that, right? Because sometimes parents will say, I know that you are 14, but I'm still treating you like you're 8. Well, that's not good, right? Not for the parent and not for the adolescent. Because the same consequences that you have in place for an 8-year-old are not appropriate for somebody who's 14, right? The expectation you have for them to understand what's happening is very different, right? So, even though adolescents want this independence, they desperately still need parents to provide structure, right? You know, when you're a kid, you're like, really? No, I should do what I want. And it's like, no, you cannot be out until 2. Bad things happen to you when you're out at 2, right? That's usually the parental fallback, right? Anybody who's out after 2, and you fill in the blank, right? Now, if you make the shift around how this impacts, how chronic illness might impact adolescents, there's a bit of a shift. So one thing that I want to kind of make note of is that when you refer to disease is the actual thing that's wrong, right? Whatever the issue is. Illness is really how the disease impacts you, okay? So when I say that I'm interested in chronic illness, that's what I'm interested in. I'm interested in how this disease is impacting children's lives and their family members. Okay, so kind of keep that in mind. Now, one of the things that we know has transpired over time is that because of medical advances, kids are not having as many struggles. I mean, this is the case with all of us. The things that, diseases that used to kill us don't. Very prime example is that when you think about our military veterans, the things that used to kill them on the field, like losing limbs or whatever might happen there, those are things that they can actually recover from physically, right? So I make the notation physically because the emotional recovery never ends, right? And I think while those seem like very desperate examples, that when you have a chronic disease, it's a lifetime. Like this is your life. Nothing about this changes. And so if you're thinking about type 1 diabetes, that's unless they come up with a cure, that's it. That is their lot in life. If they get diagnosed at 18 months, they will struggle with this until the day they die, unless we have a medical miracle, right? So even though we've had these tremendous advancements in medicine and technology, there are still challenges that we have for kids, well, not just kids, but pretty much anyone who has a chronic disease, because most of the time you're more inclined to be susceptible to depression or anxiety or psychosocial negative impact, right? Because of what your treatment is can be taxing, right? Not only physically, but mentally, socially. Sometimes they can feel isolated, and that kind of thing. So we'll talk a little bit more about that. So how this relates to us, so we know we've got this part around what happens for the individual, like increase in maybe having negative psychosocial impact. Well, but it's not just the individual. The individual is housed in a family, right? And so those same things will impact the family unit, right? So all of your systems, theory, knowledge is applicable. So you know that whatever happens to one part of the system directly impacts the rest of the parts, right? And so I tend to use, which I don't really have a formal way to say that these are integrated, but I tend to use structural language and narrative language. I know, they don't really mesh, but that's how my brain works, right? Because when you think about family dynamic, you think about rules, and you think about the roles that people have, how that actually, how it helps you to make sense of why the family engages the way they do, right? Then on the narrative side, of course, you want to know what the illness story is. What is bringing them into treatment? So I have to work on that. When I get it, I'll let you guys know. All right, so now some background about type 1 diabetes. So general knowledge, everyone, about type 1 diabetes? Yes, no, we're good, yes. Okay, so yes, it is an autoimmune disorder. For type 1, typically, kids can be diagnosed between like 5 and 7 years old, but they can be diagnosed much earlier. It depends on the condition of their pancreas, right? So your pancreas is the organ that produces insulin, and it just stops working that way, right? So it doesn't, so it's kind of like it just kind of goes on this slow decline. And so once it's done, and so that's why you have to do insulin for the rest of your life. So one of the things to note is that both type 1 and type 2 are on the rise in diagnosis for young children. Type 2 makes sense to me why that might be on the rise, because it's dietary, right? When you got people eating more fast food, or actually maybe not even faster food. like you know, there might not be as many in-home meals being cooked, right? And people are eating out more often. So not necessarily always fast food, but convenience. Maybe that's a better way to say it. More convenient food, right? And so also I think what we tend to eat, although I'm an avid Starbucks drinker, the fact that we have places that give a drink that's this big that probably has a week's worth of sugar content, and that I see kids drinking that. Yeah. Like, what are you doing? Does that have caffeine too? Why are you drinking caffeine too? Sugar and caffeine? Right? And so it's like, I think our society has made this shift in like what's acceptable around what you should be able to drink, how much you should drink, portion sizes, all of those things. So that to me makes sense around type 2. But the thing is, I can't really wrap my head around why is there an increase in type 1? That one I'm still struggling with, like, because there isn't a dietary component to it. And so, you know, I'm wondering, is it something that is just kind of evolving for whatever reason? Like, is there something in our environment that might be turning genes on? Who knows? I mean, that's purely speculative. But, so there's that little thing that's kind of bouncing around in my head, like around that. But it is on the rise. And like I said, to date, there is no cure for type 1. However, type 2 can be, right? Which, when you think about the larger society, when you say diabetes, most people think type 2. And so if someone has type 1, then they're like, oh, well, I mean, just eat better. Lose a couple pounds. Like, you should be good. And it's like, actually, it doesn't work that way. So sometimes, even though it's on the rise, there's still a lot of education that needs to happen around the difference between the two. And if you are going to be a medical family therapist, this has to be in your pocket, right? You have to be able to pull out that information and do some psycho ed about what the difference is and how to engage people around that conversation, right? Because, of course, the medical professionals, they got that one. They're like, no, we got that part. You deal with the other stuff, right? All right, so as I noted before, this is like the benchmark of health for people who have both type 1 and type 2 diabetes. So it's the hemoglobin A1C, okay? Excuse me. So if you all are relatively healthy and you're not pre-diabetic, you'd be hanging around somewhere below 5.7%. So that's the total blood sugar in your blood, okay? The percentage that would be there. As it knows, pre-diabetes is between 5.7 to 6.4, and if you have diabetes, it will test 6.5 or greater. So with our young man, Timothy, he's way off, right? Okay. For every appointment that both type 1 and type 2 patients come in, the very first thing that they do is check their A1Cs. Every visit, every time. Because this is the measure. This is what this says to me whether you are adherent to your treatment regimen. So if your number is off, that says to me, you can tell me whatever you want to tell me. But I'm going to look at that number and I'm just like, okay. Ms. Johnson? Okay. So how many pieces of pie did you have? The whole pie, okay. And so you haven't given up sugar, drink, soda? You still drinking that Coke? The Pepsi? That kind of thing, right? Because that's what happens, right? So you can't really hide what you do because of this number. And so that's why it's so important to doctors. Now this actually measures over like a 3-month span. Okay, so sometimes people are like, oh my gosh, like I ate that cake yesterday and my A1C is gonna be off the roof. No, it's not. It's because you ate cake every weekend and didn't dose, and you had some Pepsi, and you had some cookies, and you had some potatoes, and you had some high carb starches, that kind of thing, on a regular basis, and didn't dose properly, right? So when you think about, and this is also a part of like what you end up having to have conversations about with not only kids but their parents, because sometimes parents will go way over here, they go way left, because then they're like, okay, you can't have any cake. It's like, no, they can't have cake. They can have some cake. You gotta watch them. You can't give them like this huge hunk, but they can have a reasonable size, and you just have to make sure that they dose properly so that it compensates for what they're taking in, right? That's kind of hard when grandma likes to cook and thinks that, well, no, baby, you look a little thin. Come on over here. I know that's what your mama said, but we gonna eat. Right? Because grandma loves you. And grandma says, well, the way I show love is that I feed you. Because I can't, not on my, nobody will say you were hungry leaving my house, right? So this is what happens, and so then you've got family dynamics that are kind of playing into, well, how do we think about food? What, because then, so if I'm a parent, and this is what my mom is like, yeah, well, I knew y'all were coming, so I made sweet potato pie and coconut cake because that's your favorite. Right, it is. Okay, so so now how do I? Because if I don't eat what the expectation is, then how does that impact my relationship with my mom?
Yeah.
Or if my child is, and I say, Mom, like, come on, it's like you kill me. You can't do this, like, because they're gonna see it and they're gonna think they're supposed to eat this whole thing. It's like, no, you're like, It's like, so how do you wrestle with that? So we can think about this from the perspective of like what we would think about it as family therapists, but there's some family of origin stuff, self-care therapists that pops up because, you know, and I'm thinking, this is something that can come in hot, that's not bad, they can't, okay, so what's a birthday party without cake? What? I mean, you're supposed to have cupcakes, what? I mean, and so then it's like your own stuff around, well, but I don't want people to feel left out. I don't want them to feel different. Like, that's not a good place. I mean, we've all had those experiences where we felt different, where we felt on the outside. And so when kids have type 1, that's a lot of what happens. Because they go to school, and then, you know, your friends are your friends, and they're like, oh yeah, I brought gummy bears. Want some? Mm-hmm. Sure. Mm-hmm. And they're tossing them back, right? Because, oh, well, but my friend offered them to me. Or, oh, you want half of my peanut butter jelly sandwich? Sure, let's swap. I only have ham and cheese. Those things that you don't think about around like friendship and camaraderie that get established in middle school and elementary school, like how you connect with your friends over recess and break and lunch is over food, right? Rice Krispie treat. What? I don't ever have